But it is this team here in Gauteng that must go and make sure those things are prevented. We wish to see your council to come and hear how are they addressing these issues, because some of these
so that then we are able to evaluate our individual performance as per cluster and therefore also as per hospitals. The performance of the provincial hospitals in green and all the other colors you can see from tertiary, regional to district, so that we are then comparing how we have been doing. By the year 2030, we will then be achieving the 12 per 1,000 live births. You can see then in the first quarter, we were at 91 for central hospitals. And it's consistent, it's in the 30s, early 30s, throughout all the quarters. That pattern is what we are worried about, because we need to see it decreasing with the essence that starts improving. So it's the area that we still need to then look at extensively to see why it's not decreasing. Because otherwise, then it means in 2030, we'll still be sitting at that level. Our target there is 12 per 1,000 live births. I'll raise the same issue in terms of the district hospitals are not situated in the district hospital, strictly speaking. But with the numbers again, then have to improvise and put some few beds. I mean, for example, we have got beds in Bethatkowa for neonatal ICU. We also have beds in Bekimlangeni and other district hospitals. We are pushed to do that because of the fact that high-risk patients sometimes do stay at lower level of care. And it's an anomaly that as we move forward and rearrange resources, this needs to be eliminated. So, as I said, then we moved from that to go central hospitals to look at what are the challenges, what are the activities that are then put in place to respond to those challenges. In Chris Anibara there, we pick up that then the challenges are divided into nursing and doctors. And when they put that response, they are therefore responding to a challenge. In terms of nursing, they nominated midwives to attend the prenatal education program, so that if babies are coming out and they are not okay, then they are able to resuscitate and understand the issue of high-risk pregnancies. And that is done through the college. The pediatric department has incorporated the HBB, which is Helping Babies to Breathe program, so that when the baby is born right there and is not breathing well, any attendant in terms of the midwives are able to know what to do, because at times the doctor might not even be there. So then they are able to then attend and resuscitate those babies. Of course, we've got ESMO that has been running for some years. It still becomes a very good project to train both the nurses and the younger doctors who have joined the space of maternal, so that then they also are able to understand the risk pre-delivery, delivery and post-delivery as the aspect of attending sorry, Chairperson. Actually addressing on the first column, the 4 midwives are seconded for advanced midwifery course in the Chris Anibara Baragwanath. And then one aspect that that has been discussed is to start inviting midwives within the cluster to come and join the trained midwives in Bara, so that we go through the trainer process and disseminate the knowledge that have been acquired by those who went to training, by those who are remaining on the floor. In terms of the doctors, teaching what rounds have been consolidated. Daily meetings, the so-called debriefing meetings, they happen Monday to Friday. Every morning, a team that had been working for the past 24 hours will then present their challenges, their outcomes, so that then things are attended there and there without waiting for the M&A meetings that takes place once a week. the NMM meetings analyzes and put the adverse events into avoidable and non-avoidable patient factor, admin factor in terms of, concluding a particular adverse outcome, so that then we are able to come up with corrective measures within that particular week. There were the registrars from maternity rotates to ICU, so that they've got an approach in terms of critical care patients, and then interns and registrars meet the HOD every morning, as I've indicated. There are also twice a week meetings with the interns to do the ESMO, and it goes from 8 to 10. So all this is to make sure that there is continuous training, and these colleagues can then manage the patients much better. The same approach for Charlotte Maxeke. They
Dr. Mankupani, let's first, I'm sorry to interrupt you. Our request was how many women died, for example, in Baragwanath Hospital, where there was avoidable maternal death. Our interest is mostly on avoidable maternal death. The other maternal death that happens, which was unavoidable, like your slambezo, that is another story. Our interest is about avoidable maternal death happening in health facilities. For example, the presentation about Baragwanath, we didn't see if there, or unless if you are still coming, we didn't see if there was 1 or 0 avoidable maternal death in Baragwanath Hospital. If there is 1 or 2, and I quickly went through the presentation, and we expect maternal death to happen in tertiary hospitals, in your central hospitals, because they would have started there in the local hospital. Remember the role of the committee. We are not here to find you as a deep down. The role of the committee is to enhance the work of the department. We should leave here at least having suggested 1 or 2 or 3. And we expect the maternal death in your want to see how many were avoided into maternal death. It has happened. So that's, I think we were very clear that we need to understand what are the causes, the challenges that are contributing towards avoidable maternal death. It is happening. I guess it's happening. Yeah, okay, Mara, maybe let's leave him to present. We will ask questions at the end so that we do not take him off the rail. Thank you.
I think because the CEOs of these hospitals are here who must take full responsibility. Mankopane is the TDG Clinical Services, indeed they account to him. They must talk to this presentation. Mankopane, you are not supposed to present that way when Zangayo, we are smosha, because it's like aswazi umsebenzi wethu. The person that I've employed to deal, to link, to know every day what has happened, you will assist them in terms of answering the questions because they report to you. So ngiyacela, start with the first presentation. The Charlotte Maxeke, Sis Gladys, come and sit here and present on Charlotte Maxeke what has happened on daily basis to date. Same as the other CEOs must prepare themselves to come and present. House Gladys, come up as a presenter. Charlotte Maxeke first, then the others will follow. Then the person that works with you must be ready to answer if there are other things.
of verifying the deaths. For example, a facility, mortality and morbidity, where the doctors, the nurses, everybody who was involved goes and look at what happened, and at the end, that's where they will decide. Right now, as I'm sitting, I have nominated the people at Charlotte, I think it was about a month ago, and I think they first do the training on an annual basis because there could be new people, and then they are given all these deaths that have happened through the province, so that they do now the rigorous interrogation of all those programs that we have said, so that at the end, if these reports, the final reports goes into the for confidential report, at least we have been given an opportunity, but more so, the clinical people who dealt with that to be able to come and confirm that indeed this was avoidable or not avoidable. So I thought I should give that context in terms of that. The last context that I would like to give, Dr. Mankopane mentioned maternal mortality rate at 70 per 100,000, right? But in how Alpha East Rand, Pulusong refer through to Charlotte via the other hospitals. Then child, which is in Charlotte Maxeke cluster, they accept children even from Bara cluster. That's what I was talking about, that we have cross-pollination. Of those 14 hospitals in Charlotte, half of city of Joburg and the rest of West Rand. Over and above, central hospitals are Klerksdorp Hospital, Mafikeng, to our facility as Charlotte Maxeke in terms of this very topic that we are. I can't give you absolute figures, but I can tell you what we do. Every maternal death is discussed with the facility where the mother or the baby came from. I'm going to give an example. If a child does or a mother dies at Charlotte, and the first clinic he went to was Florida Clinic, and this child ended up at Rahima Musa and ended up at Charlotte. When they have that first maternal death or mortal death, those representatives from that facility come. If they can't come, because they will join, because we need to know when did the mother come to the hospital, what happened at the facility, and was EMS responsive to that? The second thing that my heads of the departments have done, the head of the cluster of ONG, he has visited every facility physically, included clinics, especially the ones where we have many challenges. Because in city of Joburg, for example, we've got many clinics you can't go. Remember, some of them do not have MOUs. That a particular hospital was unable to maybe recognize, some symptoms of the mother because they didn't have an ultrasound machine. So when we plan as the cluster for our equipment, we take into consideration that basic equipment that must be in every facility to make sure that they have it. At times, that facility is unable to have that equipment because they don't get what we call the National Service Grant. Is a grant that is meant to augment the equitable share that the province gets from Gauteng province to complement the clinical training and research in terms of improving the care and the teaching of the undergraduate and postgraduate students. So we use that grant to strengthen those facilities outside. The third thing that we have done, Prof. Chauke went beyond, because what we picked up, for example, in West Rand, the patients who were ending up at Charlotte were actually coming from Northwest. Remember, Carletonville is next to, is it Falkville? Falkville. And Falkville, sometimes people will go to Klerksdorp, but majority of them comes to Carletonville Hospital. So what we did, he went and he then said, CEO, the strategy is to engage Northwest. So we met with the heads of Northwest as an example, and in fact, Northwest has created registrars posts and consultants at Falkville. So some of those patients, because of the long distance, remember Carletonville is 60 kilometers from Charlotte, but Falkville is 20 kilometers. So now they don't refer all their patients to us. We can refer through Falkville Hospital and then support them from that. The fourth issue that he did, we have focused training of the problem. As a result, for example, if MEC will remember, in the second quarter, there was a concern about the high mortality at the districts, as Dr. Mangupani has said. So we had a focused training, and Prof. Chauke recognized that many of the doctors and the nurses cannot do the ultrasound for diagnosis purposes. So in December, I think they trained, if I'm not wrong, 27. They were overprescribed, and now we are going to do the second batch from that. And then the last one that I will raise, because my colleagues will raise the others and not take the stage for all that. Quarterly, as the cluster, we send this data to the cluster hospitals where the district managers are. So for example, Charlotte will have Ms. Karigani, who's responsible for, and at the last time, we're now going to have Mr. Choma because he's now doing Ekuruleni. So that we share this data to further pick up what the challenges are. So we have developed standardized protocols. Everybody knows that if I'm in a clinic and I see 1, 2, 3, I must do what? But if I don't have this, where do I refer to do that? We have also introduced what we call Vula app. It's still in the early stages. The beauty of the Vula app is that the nurse who is sitting in a clinic can actually talk to the doctor at Charlotte and say, I'm seeing this patient, what can I do? And he gets advice immediately on the same thing. So if you really look at our 4-year deal with this, of all these activities that I have spoken about. Rest, I would propose that we do that because they may add the other things that I have not talked about that we are obligated to do as the cluster. Thank you.
Thank you, CEO, Membukoshi. I don't know how did the questions become complicated. Perhaps one example, a woman comes to the hospital and the ward is full. The woman sitting there and they do not get any oxygen, and that fetus is dead. Is that not an avoidable fetal death? She was sitting there because the ward is full. I just wanted to make you understand. She's sitting there, there is no bed, and the membranes ruptured, the cord came out, she keeps quiet. Then later on, when you have space, you invite her to a bed. When you palpate, the cord is quiet, the baby is dead, gone. That is avoidable fetal death, isn't it? So the presentation is academic and very, very high. It's okay. But for us, we just needed to, how can this fetal death, which is avoidable in nature, for example, be prevented in future? Your records are incomplete. You did not come, your staff, operational managers did not do, and there are gaps in terms of your record keeping. And then at the end, there is a problem. We don't know how did we capture that problem. How did we waiting for bed? They must be addressed by the people in service. You can't leave them there all the time. You tell them when the water breaks, please shout. Because I needed you to say, we will make sure in future there is no problem. There is something that is foreign to you that you are not used to. Okay, let's say the record keeping is one of the biggest problems in terms of the problems that you are having with newless maternal death. I'm trying to make it simple, but I think if our questions were unclear, you could have reverted to us and say, we think because I was avoidable or unavoidable. So I'm taking it that in our health facilities, even though you hold meeting avoidable, but the one with court prolapsed, you can't rely on that confidential inquiries that come every 3 years, for example. Already the hospital, Mrs. Bugosh, will agree to say, here, this fetus, we could have saved it, or this fetus is dead because we didn't have bed, which is a problem for having shortage, or we have incompetent people who were not able to differentiate between whatever. That's how we were phrasing questions for you to come and say, we've got 2 or 3 in terms of the categories, and then you will now say in the later stage, the confidential inquiries, because that is a investigative, didn't say ask you, but you agreed with me. Investigative didn't say ask you, but you agreed with me. Operational managers, you agree with me. So we wished you could, even beside waiting for confidential inquiries, to just say, hey, here and there, yes, we are. But I wish, is Professor Chauke available one time, perhaps, in case in future? I'm not saying he should be here, I'm just asking. But I think the example that I gave is straightforward. So that woman came with, I think I will also maybe give, because we just needed how many? Even if it's the whole cluster, Mrs. Bugosh, they will say we had 1 or 2 or nothing, or if it happens like that. So, and then in another cluster, honorable members, perhaps you can assist as to how do we move forward from this, what we are now getting, because at least the strategy we need to hear, how can certain things be prevented? But in terms of presentation, what Mrs. Bugoshi has presented, I think because already he presented the entire area, the district is covered. So, honorable members, I'm now ask yourselves, what is your suggestion?
Talen Kopane and Me Bohosi, in an attempt to respond to issues that we would have raised. And I want to agree with you that in terms of our expectations, the presentations are not meeting our expectations. But I think there's a disclaimer to this expectations that are not met. Because our questions are saying, list of preventable, I would imagine if Kili acting HOD, would I really hang myself there to say, this I could have avoided, but I did not avoid it. And I'm telling you that I didn't have supposed to avoid. So it was bound, because it says to a certain extent, you are just not doing what you were supposed to do. As the chair would have given examples. But I think where we find ourselves, I want to agree with you as well, Chair, that Dr. Mankopane has given us a sense of the numbers. Maybe the, each cluster that comes, of course, I want to appreciate now I know how you are structured, which one refers for me. But I'm saying the numbers are there. Maybe those who come and just give us the strategies, because our ultimate objective is to see how you are trying to turn the corner. Is to say, acknowledging what is happening, what are you doing, and are you getting any positive results with the interventions that you are making, because you can't keep on doing the same thing and expect different results. I think that's where our current status quo. I think those who come, Chair, my proposal is that they come with strategies. Thank you.
Honorable Mfikwe.
Also add on the strategies, Chair, as to what are mitigating factors that could be employed as we want to turn around the impact of these deaths. Do we even have campaigns that we can take to communities? You know, I know women are expected to do the ANC, yes. They are expected to do that, but the education ends there with the pregnant women. One of the strategies should be, how do we involve families so that we educate each other about these possible women need to go to the hospital. You know, I mean, I can turn around your argument and say, why didn't I go to hospital before Meti break? You know, that could be another thing. When should one go to hospital? You know, so that we are properly prepared in taking responsibility. We're experiencing staff shortages, and I would be interested to know what is the other cluster saying. I hear the Charlotte cluster, that women or midwives are trained. What about the other cluster? And the training once a week, is it enough for us to turn the tide? Or should we look at possibilities of making it twice or 3 times the amount of incidents that we experience at our different hospitals? But we can't say we're doing this, then we get fixated in us doing that. Whatever we do, at a particular point, we need to do an assessment. Is it working? Is it not working? If it's working, how do we make it better? If it's not working, how do we improve and at least get it on the availability of resources, staff, beds, is there a need for doctors, medication? As mothers, we can give different interpretations as to us when we're giving birth. I had my own situation. My firstborn, MEC, I gave birth to Kamo at Bara, you know, and by the time the doctor came to me, it was, quickly, let's go to theater. And I was like, okay, anyway, the baby was a very big child. Chair, you won't believe if I can tell you the size. But the midwife that admitted me couldn't identify that Kamo is huge, you know, up until the doctor came and nearly emergency. Had to go to high care, and I got scared. I actually made a deal with God that at least good. So, you know, so how do you avoid those types of situations? It's through awareness and education of every stakeholder that uses the hospital. Thanks, Chair.
Thank you very much, Honorable Mfikwe. One of the presentations, I'm not sure if it was between Dr. Mankopane or Mrs. But there was the EMS avoided to prevent problems in future. I agree, honorable members, they are also assisting so that we move, so that we can go somewhere. You also have naughty employees. I agree, some of your employees, what do you do? Bad torture sometimes at night. Ne? Babang, they are dragging their feet, they are providing tardiness. I'm part of others are gambling, and instead of doing their work, they are busy with. I'm going to we'll do the presentation so that we move towards your. We want to hear you. What are you saying? Hey, you can't present. You mustn't do better when I'm still talking. Okay, one must be on at a time. Ne? Over to you then.
No, thank you very much for the opportunity. And only one was.
Okay, Mrs. Bukoshi, we are covered. And then we are happy with what we are moving, how we are moving. Then in future, if this comes again, you know, you will come. That one that you are talking about is what we wanted to hear about. The unavoidable. We are concerned on where we could have done some forward in future. When questions are unclear, please contact those who prepared the questions, then they will assist. Ne?
Thank you. Thank you.
In this case, the cluster will just perhaps tell us their records, and they will say we had so many of avoidable maternal death, but we don't want to put you under pressure. Thank you. You are from the ropes. Stand up and just stretch. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. At least you can't sleep. And you must stop ropes if you are doing it.
Freelancing.
You must stop ropes. Are doing it with government. I know you may do it in private. Then you come here and you are tired. Thank you. Is the North. The North is going to do their presentation.
Honorable MEC, Meno Mantu, Ralohokunkomo, Chair of the Portfolio Committee of Health, Dr. Dikhamele, Honorable MPLs, and also fellow colleagues on the floor. Greetings, my name is Dr. Lihlonolo Majake Mohoba, and I'm representing the Steve Biko cluster. This is a presentation that has also been inputted by my fellow clinical heads, Professor Soma Pillay and Professor Smuts, as well as Professor Basu, who are not here but have indicated that they are willing to move forward with us in unison. And of course, I also want to recognize Mr. Pitsi, who's the head of the district within the cluster. So the Steve Biko Academic Cluster has several facilities similar to what Mebohoshi mentioned earlier on, that it incorporates on the district level. The Tshwane Health District has got 5 sub-districts, which are 3, 4, 5, 6, and 7. Sub-district 3 has got Tshwane District Hospital, Pretoria West Hospital, Kalafong Provincial Tertiary Hospital. 5 has got the Lodium CHC, 6 has got Stanza Pupape CHC, as well as Mamelodi Regional Hospital. 7 has got Dark City CHC, and also Bronkhorstspruit District Hospital. In Ekurhuleni, we also take in Esangweni and Tembisa Provincial Hospital, as well as Ethafeni CHC. And then we also have just a tip of sub-district A, which is...
Chair, can I intercept, please? I think in the interest of time, can we just go to strategies, Chair, if you allow? Because we still have other clusters to come and we still need to engage. With due respect, Chair.
Thank you.
Okay. Proceed, Doctor.
Our strategies, we've got several ones that are divided into different things: administrative, staff-related, as well as community-related in terms of behavior. For administrative ones in the short term, we certainly believe that we need to increase facilities between the transportation between the different facilities, whether it's between the hospitals, district hospitals, and the central hospital, and also to enhance the GSET. One of the biggest challenges that we have is the waiting time for various radiological investigations, especially with people who come to hospitals such as Steve Biko that need your cardiac sonars and so forth. So that is one thing that we definitely need assistance with, and unfortunately that's also very much human resource related. Of late, there has been a suggestion that we introduce sonographers, but our current structure doesn't accommodate sonographers. We also need to have extension of theatre time, especially after hours. If you look at the Tshwane District Hospital as well. But then again, that needs human resources, which we don't have. We don't have enough staff. And then I think the other one Ms. Bohoshi spoke about the EMS delays. In the long term, especially when you look at places such as your Tembisa Provincial Tertiary Hospital, I think definitely there is a need for a separate mother and child unit. and there is motivations that's actually been done for additional, more dedicated ICU and high care beds. But we know that as you increase high care and ICU beds, you also need to have the specialized nurses that are ICU and high care trained. And then with regards to overall high care management, high risk district, we do need to have improved antenatal care, regular checkups, screenings and monitoring of high risk pregnancies. We do realize a lot of women do come into hospitals very late. So we need to have a way similar to what was done historically, where we have more health promotion about a missed period as a pregnancy, and you need to go early enough for antenatal care. And I think we do need to have more standardized protocols for early detection and management of complications during pregnancy and delivery, such as diabetes and preeclampsia. But I think another thing that really is important is a lot of the patients who end up demise because a district level will realize there's a problem, referred to a tertiary level hospital or central hospital, but we don't have enough people who can actually catch the condition before it topples over to become too severe. So access to cardiologists and intensivists, especially at Tembisa and Mpumalanga, is highly critical. And also a specific obstetric medicine physician, particularly in Steve Biko, would definitely help. And then, of course, enhance MOUs by further training with ultrasounds. This is something that Professor Somapile is going to be looking at, including giving sonars that will actually help with looking at the blood supply and the umbilical cords. One thing that we also want to really punt for in the long term is to use safe telemedicine. Currently, although it's not the best, we are using what we have through communications, WhatsApp and so forth. But I think telemedicine will help because we only have so many people who are working with us from a specialized perspective, and very few individuals that can actually go physically into the cluster. But I think TOP services, we are realizing that more and more people are doing unsafe TOPs, so that is something that is certainly needed. In terms of healthcare professionals, as mentioned by Mayor Buhoshi, the M&Es should be held within 7 days. We are monitoring that. It is currently taking place. Some days, though, however, they do prolong. And we do need to have more training on the ESMOs and EST. From a patient perspective, health education is very, very, very important, and adherence to the antenatal care visits. We need to have ways of having more CTOPs that are safe and have outreach services for these termination of pregnancies, and also just behavioral interventions at primary health care level. This was just a diagram that showed more neonatal, because the question was neonatal and also maternal that we had. But similarly as well, the intervention strategies is, as mentioned, let's tackle the early bookings. Let's tackle substance abuse. It is also a big problem. Let's tackle the unsafe pregnancies, and also increase training of our personnel to manage the maternal complications in the district level itself. And of course, data-based decision-making is important, but we need the tools to enhance the data. And I think these are basically also repetition, but now in the baby setting. Definitely NICUs are a huge problem. Steve Biko, for example, only has 7 ICU beds for peds, and 10 neonatal ICU beds. It's nowhere near enough for the scale of the people that we take, in Mpumalanga and so forth. So that's one thing that's a big problem. And human resources I've mentioned, so we need to bolster that. And of course, IPC is one thing that we realize is a challenge, but we're looking at having ways of closing down our IPCs where only consultants and registrars get in and no longer the lower categories, just as a way of making sure that we prevent the thorough flow that go through. So I think I've mentioned the bulk of them that are listed here, the SOPs, the meetings and so forth, and I don't want to repeat in the interest of time. Thank you.
Thank you very much, Dr. Majake Mukhuba, the CEO of the newly appointed CEO of Steve Biko Academic Hospital. Thank you very much. Can we have the third cluster?
Good morning. A very good morning to the members of the committee, the Honorable MEC, advisors to the MEC, and all the senior leadership that is here, the community at large. My name is Dr. Ntabiseng Mahana, and I'm the newly appointed CEO of Chris Hani Baragwanath Hospital. My presentation, but I will just go through the cluster. Chris Hani covers as well as Telle Mokgwerane. We've got a district hospital that is big. Of the strategies that we have, we are going to discuss just the operational ones and then also just on a broader perspective as a cluster, cross-cutting issues that the previous CEOs have spoken to, so we won't go to that. In terms of the strategies we have done in terms of human resource, we have nominated midwives to attend the PEP weekly at the nursing college. We've also have pediatricians who have introduced the Helping Babies to Breathe program for all staff. Every month, 2 midwives are sent for ESMO training in the district. 4 midwives are seconded for advancing of maternity nurses. In terms of the doctors, we do have our teaching ward rounds that are held twice a day. And we've got weekly M&Ms. It's not even showing. It's sent to the technical team at the back.
Answered, those that are beaming the presentation, it's not moving or it's not even there. And she said she gave it to you at the back. Can you assist? Oh, okay.
You're sleeping on the job.
If you can continue talking while we are waiting.
All right. So we also noted that one of the reasons why we have avoidable deaths is because most of our registrars, including the personnel on the ground, are not trained with the ICU. So we have started to do workshops and rotating registrars, including some of the nursing personnel to ICU, at least on a weekly basis. Other mitigation strategies to reduce the neonatal and maternal deaths, we want to improve access to quality prenatal care because we have noted as a cluster that our issues are actually starting at a community base. And not necessarily, by the time they get to the hospital, it might be a bit too late. So this involves in making sure that the pregnant women get access to regular prenatal checkups. That's where the clinics also come to play. And we monitor the development of the fetus. Not only that, as a cluster, because we do have specialists, we are also enhancing the skills of the clinicians at the access to emergency obstetric care. We've noted that skill gaps are there, especially with midwives in terms of training and the doctors. And these play a huge role when it comes to safe deliveries. We can move. We can move on to the next. Right. We have also then, you would hear that in the first slide, we were speaking a lot about education. This is an important part when it comes to developing strategies that we need to educate and also train our midwives including the clinicians. We also want to improve the healthcare infrastructure because that plays a huge role. I would have heard from one of the committee members talking about waiting times. And sometimes when we look at waiting times, we focus a lot on the personnel, but it also should be noted that infrastructure challenges can also impact when it comes to waiting times. So we also want to look at infrastructure by making sure that our maternity wards, including the neonatal facilities, are up to date. So, but one of the other things where the community is also involved is promoting of family planning. Family planning allows women and couples space for pregnancies, and they limit the family size according to their desired goals. So access to contraception and family planning services not only reduces the risk of unintended pregnancies, but also allows women to plan for the pregnancies when they are in good health. Sometimes you find patients that are stage 4 RVD, that are stage 4 HIV, being pregnant. And if you find patients like that, if they were given access to prenatal care or family planning, perhaps they would not then be pregnant, and they would only be pregnant when they are healthy. This is something that the MEC is really emphasizing when it comes to implementing community-based interventions. We note that we are not a silo department, and we depend a lot on the community. So engaging communities and teaching them about maternal and neonatal health promotions, this is also important so that we can raise awareness about the importance of seeking skilled care. The chair spoke about mothers who go to the taxi rank for perhaps aloreka sihlambezo. Those are important things. We should go out there to the community, to the taxi rank, and talk about the dangers of taking isihlambezo. So that's also important. So the community-based intervention. But not only that, we would note that the socio-economic factors also play a role. Poverty, lack of education. If patients don't have that education, lack of, also having gender inequality significantly impacts maternal and neonatal health outcomes. So when we address these underlying determinants of health through the interventions such as, poverty alleviating programs, girls' education initiatives, these are important, and women empowerment efforts can help improve access to health care and reduce maternal and neonatal rates. Chair, you spoke about record keeping, and we are in agreement. The antenatal record keeping, we note that it does have some issues. So we've got the antenatal care records, the birth records, but this is the third point that we wanted to push. The Department of Health, Gauteng Department of Health and Wellness is actually pushing the issue of electronic health records under the leadership of the MEC. And there is much work that is being done in that regard. So hopefully the safekeeping and the actual record keeping will actually improve just by implementing this. Not only that, we take it a step further and we look at the data analysis and monitoring. So when we look at the regular analysis, it's done at a quarter implementation, but also annually, we're able to go back and look at the root causes that might have, caused maternal deaths. Patient education and empowerment is also important. So access to personal health records empowers mothers and caregivers to actively participate in the decision making, and we know that these are part of the patient's rights. Next slide. So how do we then improve the access to quality? I know this is a contentious issue when we speak about expanding health infrastructure, but it is one of those things that we need to talk about. We note that the MEC has implemented TISH, the Premier has implemented the TISH. But what the MEC has also done is that, in collaboration with the rest of the healthcare workers, is mobile clinics. And once we start implementing mobile clinics in those spaces where it's difficult to access, I remember I'm from Ekurhuleni, and there's a place called Marikana. When we went through the reasons why they have born before arrivals, we noted that it's because the ambulance actually cannot go into Marikana. So these, when you get mobile clinics, you bring a clinic to the people where accessibility is an issue. CEO Majake spoke about telemedicine. We do have those WhatsApp groups, WhatsApp calls, but we want to have a platform where if I am seated, if you're seated at Sebokeng, you're able to get, the picture of what's happening to a patient that is at Bara, and vice versa. The clinician that is at Bara should have a picture of what is happening in Sebokeng. One of the other things that we have noted, transportation, and these are important stakeholders, your EMS, making sure that there's availability of EMS. One of the patient must be at the right level of care at the right time and being seen by the right or the correct level of personnel. You would note that most of the people as well that we are also seeing are patients that are coming from outside the province. So having culturally competent care, for example, being able to speak Sepedi or Setswana to a patient who comes from Northwest, being able to speak Swati to a patient who comes from Mpumalanga, actually helps with the outcome. Competent care is also an important thing. And I have stressed about the education and awareness campaigns to make sure that we are able to get a health-seeking behavior from our community. I rest. Thank you.
Lestot, Dr. Majake presented. You didn't clap. Dr. Mankupani presented. You didn't clap. To thank Dr. Ntabise Mahana, the brand new CEO of Bongwe. Kiri Namo, that we are saying that. Siabonga, MEC. Now, I don't know if Mr. Piti is now and the North has presented. Are we having the North West now? Okay, because okay, Dr. George.
Look at the Dr. George Mukari cluster. It's mainly serving 2 sub-districts to the north of Tshwane, that is sub-district 1 and 2, which covers the areas of Mawiga, Pretoria North, Montana. Very peculiar cluster. In that of all clusters, it's the only one which is comprised of district hospitals and no other level of care. And the 2 district hospitals that are in that cluster are both on the boundaries with Northwest. So that immediately indicates what kind of patients they have to deal with. They're not just serving, the majority of the patients they serve are from Northwest. And for Jubilee Hospital in particular, over 2/3 of the referral primary health care facilities in that hospital are from Northwest Province. But broadly, we're dealing with the same issues, but beyond that, we have Dr. Mashamba, who has come up with a program of taking patients with low-risk patients facilities where they need to be delivered, whether it is at an MOU or at a district hospital, and with support from Dr. George Mukari Hospital, that some of the cesarean sections, for example, can be performed at Odi District Hospital rather than at Dr. George Mukari Hospital. And that releases beds at Dr. George Mukari Hospital to enable them to deal with difficult cases that they should be managing rather than being clogged up with low-risk patients. So broadly...
Okay, let's thank... he is also a brand new Ali Bongwe for Abu Baba. How is it? But so we thank you, sir, for that presentation. I'm going to ask honorable members to, everyone is here to answer. Then we will come to you, number 1.
Thank you, Chair. I just have 2 questions from the Steve Biko class, disappearing patients. They would have started the ANC process, then they disappear. So my question is, do we not, or are we not thinking about having a tracking system? That says, because when we haven't seen her, then can't we follow? If we don't have a tracking system, is there a thinking of establishing sites so that you don't lose, because that is where then mortality will come in, because people are going to present very late at the hospitals.
Mbara. No, I think Dr. Mbara Piti said many of the issues raised by previous.
Back referral is made about Caesars. And look, Caesar becomes part of the challenges in our hospitals, you know, and if you are referring a hospital that refers and the hospital that receives, so that there is no problems in presentation of the patient going there. You know, my worry is arriving there and they say the child is in distress because of, you know, because I picked up that those operations are installed. So for me, those are the two questions. But given anything, I'm a bit happy about all the clusters seems to be putting in. We just need to up the ante so that we prevent more deaths and we became what we are supposed to be doing as our responsibilities to save lives and preserve those lives going forward. Thanks to the presentations, Chair.
Thank you.
In welcoming the presentations, I think in my earlier input, I would have had a disclaimer, given the context or the environment in which this presentation responded to. And obviously, even the responses that we're looking for, because they are generic one, that is why the other cluster will just say, "Ke la ka leo." And the reason why we would have wanted each cluster accept "Ke la ka leo," because the responses are now generic. All what we are having here, you are saying these things are beyond reach. To a certain extent, Chair, I don't know whether I would have, we need a new ICU. You are saying to us, without this ICU, we can't see anywhere. And our question was, the unavoidable. I get it, Mutula didn't go banking, Hanyake ICU, if I were to refer. And those are just simple, and it's going to be on the radar forever and ever until that infrastructure is corrected. I think we are pushing it somewhere else than just to say we should have done this and this is how we are going to do it, or this is how we are doing it. I'm not hearing anything about consequence management. Because remember, we are speaking about things that you could have avoided. So in case somebody...
You to see them, you must write the correct time, teach them. I only see her now because the ward was busy. Isn't it? I know, I talk about things that I know. You can't adjust 2 hours back to say you saw her 2 hours ago when you didn't see that person. You can't dodge, please. Number one.
Thank you so much, Chair.
Sorry, everyone, they must tell us who they are and where they are working, which hospital, which clinic. We need to at least have an idea that at least those that are talking, they are also representing their institution. Those that are quiet, their institution is misrepresented.
Where's the camera? Okay. Thank you so much. My name is Dr. Siseko Kola. I work at Telemukharani Hospital. I want to first thank the MEC together with CEOs, specifically for 2 hospitals that I've mentioned, Petha Klowa and Telemukharani Hospital. We've seen great improvements I think since the year of 2020. We've seen what's happened with our states when it comes to mother and child care. 2023, we're looking at infrastructure and support that we get. Yes, we still have challenges that I want to speak of, specifically when it comes to support with midwifery in the departments. We've heard stories that it's related to that midwives are not applying, posts are available, but there is concern with a ratio. There's been recommendations that have been made, and how many midwives should be in a particular ward or in an area is to the number of patients. We thank the support for the doctor side. theater is still a concern where we find now there is a shared theater between gynecological emergencies with obstetric emergency departments where obstetrics has been receiving the support, but if there's a gynae emergency that must come into the theater, then you find that the team gets to have a challenge. And we've given recommendations to management to say that can they show that gynecology is an entity on its own with, I think, the great improvements that are there. I believe it is going to happen. Record
To a PM that's working at the hospital level. Fine, I just want to say to my colleagues, let's go back to basics. If we support each other and managers of different facilities, some of the stats that we are seeing, we can actually decrease.
Requesting on your behalf that MEC organize symposium for midwives. Clap hands for me.
Going to happen.
I am biased. There must be a symposium to come and talk. Thank you. Number 3.
Some have worked for us, like we collaborated with the district to ensure that we decrease the number of women that are dying during the puerperium period. So this we do by referring all our discharged patients in our postnatal to one of the DCST members so that he assigns the WABOS group if there are no follow-ups done within 3 to 6 days. And this is working well for us. And then there is also a collaboration with the district. If there is a mother who is struggling with breastfeeding, we also do the same. We send the names to the district where they will follow up this mother at home so that in a way we are fighting SEM and MEMS that are there. And we also have collaboration with the surgical department. Their consultant are the ones that are coming to postnatal for upskilling of our own doctors in the unit. If there is a wound that needs to be discussed with surgical department, they do come for upskilling of suturing and other issues, and that has led to decreasing number of septic cesarean sections in the units. So we do have avoidable deaths, and we work on that. Thank you, Chair. The other issue is the ART defaulters. When you check all our maternal deaths that are avoidable, the common factor amongst them is the ARV defaulting. So we are teaming up with the HAST team to try and find the way, how can we best do this? It becomes a problem in our units. Thank you.
Thank you very much. On the home visits, you need to also make use of the structures in the community to avoid attack by thugs, because we've got a sophisticated thugs. You know, they plan ahead, and I know they once raped some of the nurses who were doing postnatal visits. I think it was in Johannesburg, but it's some time ago. So those are good things, but we need to make use of the community structures for protection, because you can't have police to help you in that. You know, also the EMS are being attacked by the thugs. They know the equipment in the EMS car that is sophisticated. So on that one, you need to please make use of those what do we call them? The people that are CPF and those panyas, they are very helpful, the wardens, so that they protect you. Don't do it on your own because of love of it, and you end up also having problems. The wardens are very, very helpful. Number 4.
Good day, colleagues. I'm one of the managers from Tembisa Hospital. The first challenge that I would like to actually share with the colleagues is sorry? Oh, Nontlatla Sibiya.
Thank you.
Yeah. It's the issue that my previous colleagues have talked about, the shortage of staff, especially the specialists in maternity. Because you find that at times you do advertise the post, you get the candidates, but they only stay in the department for less than a year and then they leave the department. And it's very challenging, especially in the institutions where it's actually busy. They want to actually leave those areas and go to the areas where it's less hectic. And you find that you get a challenge when it comes to allocation of staff, because each and every shift, it's supposed to be led by a specialist. And you find that some of the shifts are led by non-specialists. Not saying that they are not good at what they are doing, but the requirement is that they should be a specialist that leads the team, especially in maternity. We have recently had a SANG visit, and they also highlighted on that factor that we need to make sure that the shifts are led by the specialist. And it's a challenge because we've tried, but you find that people, they come and there's a whole lot of staff turnover. It's very quick. Then the other challenge that we are facing is the challenge of overcrowding. The scenario that you have just made, Chairperson, it's the thing that we witness almost on daily basis, where you find that the unit is actually crowded and some of the patients, they have to sit on chairs. And it's not consumable, especially to pregnant women. Even in antenatal ward, we face the same challenge. Even in labor ward, we face the same challenge. And it's worse if there is an adverse outcome. It becomes very, very traumatic. And we have actually tried to down refer to say there's those low risk patients, can they be down referred to the clinics, the nearby clinics? The system is there. We are actually trying to make it function, but you find that at times even the patients that you down refer, later on they will come back. That I would like to put forth is the debriefing of midwives, because the midwives, they work under very stressful conditions just to motivate them, but at times you can see that they are overwhelmed. So I would just request if there is anything that can be done, maybe from the province or the national, just to debrief these midwives, because at times they are trying their best under very challenging circumstances. Then the other issue is the shortage of consumables. At times you find that you have to actually improvise as a midwife. And if you improvise and there's a negative outcome, then it comes back to you. Yet you know that you have been requesting for items and then they say they cannot supply them to you. You also try the other institutions to outsource whatever that you are short within the unit to try and give the best patient care that you can give. So we would actually request support also from outside the institutions. I know our managers, they are supporting us, but we will also request that our challenges, as we are putting them forth, they can be addressed. Thank you.
Thank you very much. Can we go to number 5?
Thank you very much, Chair. And Ekuru Lane is one of them, as we fall in that cluster. We looked at that, and what we have done in the district, we have identified old unused buildings. We have met with the real estate to actually increase the number of bases, EMS bases in the district. That arose when we had a problem with a patient in Etwatwa, where this patient was actually waiting for the ambulance, and that ambulance had to actually move from Far East Rand Hospital. So we realized that there's a need for EMS bases to be increased. So we have done that in Philip Moyo, and we have seen some benefits in terms of shortening the distances where EMS has to go and assist. And we are busy also engaging with real estate to actually go to the north, and Spartan Clinic is one of ours. So shortening the actual distances which EMS has to travel is actually assisting us a lot in terms of response time. The other issue that we actually identified as a challenge also, and I think I agree with my former at hospital level, is
To call ambulances, that one please, as the department, please look at it, it's an emergency. Thank you.
Thank you very much. Number 7. And I think there is also... Aye. Give her, and then there are 2 people this side.
Good day.
Hello.
Thank you very much for this opportunity. I'd like to greet everyone, the Dr. Dhamele, MEC, hospitals that we are referring to. Thank you very much for being here. I am Estanka Dimeng. I am the operational manager for OR Tambo MOU in Diepsloot. I'm not only going to speak about the challenges, I'll also speak about the things that we are doing in order to try and improve our situation. OR Tambo is a clinic which is very far from just here and there. So the first one that I would like to speak about is the lack of advanced midwives. We've been operating without advanced midwives because I was the only advanced midwife and the operational manager also. When she moved to Ebony Park, I was appointed, so we don't have advanced midwives. But the good thing about this is that our district and sub-district are helping us, they are assisting. We have ESMO. We make sure that all our midwives, even though they are not advanced, they are trained on dealing with that. I've been working there since OR Tambo opened. We never had any maternal death. So another issue is that it's helping a lot with the neonatal resuscitation and also the helping babies breathe. Didn't have any doctors, so the midwives were able to resuscitate on their own, but now we have doctors, they are assisting also. We have our monthly M&Ms, so those also helps us, especially when we have the neonatal deaths. We are able to do the case study with regard to those and try to see where the problems were. But what I would like to mention is that most of our neonatal deaths that we have are the mothers who have delivered at night at home because Diepsloot is very dangerous. They are afraid to go out. So someone ends up delivering premature babies at home. Imagine how is that person going to resuscitate a preterm baby. So they come to us, the baby very cold, and you find that the resuscitation fails because of that. And another one is that we do in-service training, but most of the time it's so busy that even if you as the operational manager want to do in-service, you can't because they are delivering. But maybe the good thing is that we still have 2 shifts that have 4 midwives and 2 that have 3 midwives because one resigned and one is doing advanced midwifery. And the EMS also is a problem because they are not catering only for Diepsloot, they are catering for other areas around. So we find that you have to wait for an ambulance for a long time, and I was asking that maybe the MEC can help that, especially for the mothers, if it's possible. I think that will help a lot for the mothers, if it's possible. I think that will help a lot. But another one is that our mothers also, high-risk mothers, come, you find that she's cardiac, she never disclosed to anyone, and we only recognize in labor ward. So you find that the mother is very critical, goes to Rahima Musa, and ends up passing on at the hospital because of the Sizague campaign that we are doing in order to make sure that our mothers are booking very early. So I think that also is helping us, the trans, without taking them to Discover's hospital where we have only one slot once a week to go and wash our linen there. So that's the things that we are facing. So thank you very much.
Thank you very much. People are now out of order. Number 9, 8, sorry.
Good day, executive leadership and political office. Thanks very much for add on some suggestions that are, or strengthening services that are there in the department. We have noted that one of the causes of maternal death. Oh, my name is Bitumelo Langa. Sorry, I'm the acting director.
Let's give. Choma was lucky. You should have been a manana there. When I Choma, you sweet it. Let's go there.
What? From South Rand Hospital.
See, we want this one, not you, Miss Langa. When are you part of?
New, he's just 7 days.
When are you a part of?
But he's coming.
Isolated to one institution is staff retention post training. We train nurses to specialize, and when they come back, we don't have post. So to the portfolio committee, I would like to request that as you bargain there, look at the issue of post in district hospitals. And another issue that was raised here is creating of specialized units in district hospital without the necessary post and funding for those units. It creates a problem that we end up using staff that is not qualified to do their work in those areas. So if the committee can look in that issue and come up with solutions, I see that HR is here also. They can assist us. Thank you.
Thank you very much. We thank you very much. Before I even forget, I want to thank you. You have compromised yourselves during COVID-19. You were in the everywhere doing work during difficult times. As a committee, or on behalf of the committee, we appreciate you very, very much. I'm going to hand over to MEC for their responses, then we will do the final closing. But maybe of skilled midwives. And I think our topic is sustained shortage of skilled staff towards improving maternal health. They mentioned the issues of patient ratios, training, workshops, but none of them is mentioning the issue of discipline. And it is, yeah, there can't be. It has been there. It's part of healthcare, you know. It's even worse because people, it's some kind of a right, you know. So it is working, you know. So the issues that they are raising here, I think they are the ones that will have contributed towards some of the problems, but they are shy to mention the issue of ill discipline. That can also look for one cell phone per hospital that they can use, then you control the airtime. Because I know sometimes they will use that airtime for personal use. I guess it is not MAGA. Because the landlines were there, people were phoning all over, and others, they even phoned. Then the bill was so high. Fortunately, the management is not, these people, they are also doing a great job. I mean, the department. They phoned the person in America. No, it's my mother. My mother is Rebecca Dihamela. She's working there. We spoke for 30 minutes. How much? Who must pay it? The department. So the control measures still have to continue to the party. They also sometimes release incompetent people who do not, who didn't meet the criteria. They go through, and where they train large numbers is a problem, because that's where there will be those that are going through. Also, as I'm handing over to you, I want to acknowledge the presence of Dr. Mluku in our presence. You are welcome, sir. We always derive wisdom from yourselves. Yeah. So now, I don't want to go lolo because we are hungry because of austerity measures. Handing over to you. MEC.
Thanks, Chair. Chair, HOD is going to answer some of the questions but I know the issues that they are raising, I know them. And I think they know because I've been in their institutions. Abangatotshi bayayazi ba akhona esiyi-1 isibhedlele engayanga kuso, not once, not twice, kwezi ibhedlele zenu. And the problems that you are raising, we are picking them up. That is why zingekho ninzi problems abo. It's because we are dealing with those problems, including this one, Chair, of the telephones. HOT will talk to that, but already we have a plan of having a system that is not going to be too much expensive, that is going to be installed, because we didn't have the CIO. Now the CIO have started. I remember when I spoke to him on Monday, that was the first task that I must do. We can't have hospitals or clinics that doesn't have telephones that are working with that minimum, especially now in this era, because there are those packages that you can get that are easier, that we can be able to carry as a department. The issue again, Chair, of when I get into the department on the 7th of October 2022, I was shocked that we are not training nurses or we are not reskilling those that are there, because I am for skills development. We have strengthened that unit now. We have a girl called Samantha Ngidi that is responsible, is the one that was working with Dr. Mahana with this campaign of I Serve with a Smile and Care, but he's responsible now specifically for training. HOT gave him that responsibility. We are working with TVET colleges. We are now bringing in the nursing colleges because they thought they must do things to hospitals because they tell good papasil. So we want to do things by the book, working with, and this party midwives that are not there. It's one of the areas that we felt that it must be priorities there. It's not a myth that they are raising something that is there. Some are leaving because of the age. Not everybody, because most of them, they are old. So that's why we are prioritizing the issue now of skills development in the hospital. Our EMS have been centrally at some stage. Now we are decentralizing everything. We want you in the communities, members of parliament, to plead with the communities to protect the EMS, to respond on time, to respond even if it's at 12 midnight. Because now, because of the killings that are happening in the EMS, they are scared to go out in specific areas, especially in the informal settlements, when they are being called, because they don't come. Equipment that is in those ambulances are taken. But I'm sure now, because even the municipalities, Chair, we're delaying the memorandums of these SLAs that we wanted them to sign, of bringing now to have some of them to fireplaces, so that it's having our own security. Consequence management, Chair, we are doing it now. We're not doing it in the Department of Health. If I can give cases that have been there of people that were even unable to touch them, Chief Director, even if a person has stolen something, nobody touches that person. So, but now we've changed that. I'm sure you've seen it, Steve Biko, we've suspended 4. At Tele, we've suspended that report when I was there at 12 midnight with yourself because of that case of a child. We suspended those colleagues. And the unions are taking us up, but we're fighting with the unions because we're telling colleagues that these are the colleagues that must lead by example. So when there is something wrong, so that we can have a process that we follow then to bring him back in the system. As we push it, but at least they must follow, must be done. On the spot, once now, the department will not be right if we were not doing things the way now that we are doing, Mama. You know how things have been, and we're not proud that. But when you are with them, they are very nice, but you do something wrong, they are going to fight with you within a minute. So next 2 minutes, there's something wrong that you are doing, we deal with you as if we have never laughed with you. And I think it's helping even at the national office, taking it, because the central office now, that is supposed to manage colleagues and assist them. They were not doing these things the way that. In Sibukeng, we've suspended a woman, that there was a woman that was giving birth, and something happened on the child. We suspended that colleague. So I think where there is a mistake, we immediately now act. I will leave it to HOT Chair to answer some of the questions. But before I even give it to HOT, I want to apologize once again for not understanding the question and exactly what you wanted. Besides the issue that we were unable to give you because of the
annual year, financial year. It will be proper that when we get that report that talks to the 4 quarters, we will come and present to the committee exactly what we want, because now it will be an information to those issues properly, and I'm sure you will definitely get that information, Chair, once it's released by the national and the NHC. Give us a go ahead to do that. Because when we were caucusing at the end, it was the fear that I must not be seen releasing information that is going to destroy the government. Processed properly by the minister, and I don't have that info, because in fact, even in the letter, I should have clarified to how far I should go when I present to this meeting today. Because that one itself, it creates ill discipline towards myself, because I'm providing you with information that I know I am not supposed to give. This one, that's why they're even saying safety in the province. Faith waits for Cele to release the information. And we do that even here in health. Kulen information because it talks about lives, people that have passed, but it talks about deeper issues that is created, why that environment happened. And I think I want to invite you to go to Roundtable clinic one of the days when you have an oversight. I know the FIS here, if you got the FIS, Roundtable, that Lasisi Loana, she's one of our best facility managers that I've come across in the department.
Then we can clap hands.
Things that she's raising, they're doing it. I've even stolen now that Sizakuwe campaign yabo. I've stolen it because we have local promotion programs that we are doing in the province every week of going to the communities, linking them with HAST programs. But the Sizakuwe yabo bona, it even talks to the pregnant young women that are defaulters. And most of the defaulters, as she was saying, are the people that are positive. I learned from when I was listening to them, visited the Tambo Institute facility too. The good work that they are doing there. They don't have much resources, but the little that they have, and they never complain about resources to me. Even the issue of the machine that she's raising, we are going to provide that machine because we're just waiting for in the meantime. We're also waiting for the transformer so that that area that is laundry, which is bigger, it should be working. With saying that no HOT and uputu kona uputu emali kona uzawundinika because there's bandlali ngemali yakhe. Symposium chair propose that we do it before chair before end of April, so that we give ourselves time for the planning of the symposium. That will bring colleagues because it will help us again. You can see the sharing of experience of the colleagues here that they are doing. It will need indeed that symposium that will lead us to the reduction of maternal death. Then we'll broaden the scope and bring even other professors, the professor from Charlotte McClake that helps us, not Dr. Nwabe, because it's part of the people that are assisting us on daily basis to ensure that we reduce the maternal death in our hospitals, especially because I'm very touched with issue abantwana city. You know, I lost my child in the hospital on the day of delivery. So that's why when they see me in the city, where is your PIDS? In my mind, I'm still trying to heal because it happened in 2003. But in my mind, I'm trying to heal because I always think about the woman that have left that child in the PIDS, about the woman that didn't get out with that child in the PIDS unit, because I'm one of those that didn't get out of my child in the PIDS unit. So that's why my attachment on what you are asking us to deal with today, it's critical. Because it will raise, in fact, once we clear this, we'll even be no longer be called an underdeveloped country. Because we're charged by the maternal death in our country when they are doing the states international WHO. Once we reduce these numbers, we'll definitely be one of the best countries because of this issue. But thank you so much, Chair, for understanding that we're a bit disorganized when we arrived, were to release other colleagues to go and mend the hospital because of me not communicating with you, because I should have done that myself. I take full responsibility, Chair, and members of the committee. If you allow me, Chair, I will ask Malotane then to answer some of the questions that members have asked.
No, thanks, Chair and members. Maybe, Chair, to reiterate and also take full responsibility. I am the one that removed the numbers from the report. And Chair, we removed the numbers from the report because one, the MEC explained the issue about the process that needs to be unfold. But also, Chair, it became clearer during the course of the meeting numbers because they are facility managers. There was an impression that was created that is a public meeting because it will be 300 or 25 without saying out of that 100,000 they are authorized, as the MEC indicated. The level of detail we have, Chair, per quarter on those numbers goes as far as those that are registered at DHIS, those that are provincial register, those that have been, the assessment, Chair, is very important because it follows that confidential on the mamas match. Then the minister releases those numbers because then it means there's no discrepancy between what facilities report and what the national process guideline provides. And once the two matches, then we are confident that these numbers that we are reporting are accurate. Chair, the level of detail in those numbers goes to how many of those deaths occurred outside the health facility, how many of those occurred at the CHC, how many of those deaths occurred at the district hospital, regional, and including private, Chair. We have data from, because unavoidable death, of course, is a reportable, Chair. We have even including private data at an appropriate time, as the MEC said. We will then come back and share that data. And the MEC has already apologized for just maybe the misunderstanding. Chair, there are certain generic issues, maybe to explain why it might also sound like the interventions are generic. When we came out of the second quarter, there are 3 areas we are not doing well currently. And Chair, you'll go back to the report. As far as TB, maternal death, and EMS were the indicators that were not. So we had a session to review our performance. So the reason it sounds like it's the same intervention is because there was a process, a workshop to consult everyone and then say, in light of these numbers, how do we respond and intervene? And maybe that explains why some of these issues might sound generic. But Chair, maybe just to reiterate, and I will not be long because the MEC has dealt with most of the issues. There are certain issues the health system, despite its effort, is struggling. There are patients that present to ourselves once in a lifetime. They arrive late with no history of ANC, no history of anything else, deliver and disappear. It makes it very difficult to account and record such patients. There are patients that come with no history of ANC at our facilities and they are complicating. Those patients also present themselves at the wrong level of care. Part of the complication is that process of then having to assess, pick up an issue and refer them to appropriate facility. And Chair, I will not even get to patients that arrive in the morning with the bus from the SADC countries and then present ourselves, especially the facility that happens to be in urban settings, Chair. And after all this is being said, Chair, there are deaths that are unavoidable. And then I think that is not the issue of contestation and here. Chair, lastly, maybe, and this is what Member Mfekwe asked about, a patient that is not being traced and recorded. It's the same challenge, Chair, we're having with our TB loss to follow up, the same issues we're having with our loss to follow up patients. To say, until we get as many of our patients in an electronic patient system, because that automatically are able to schedule patients whether or not they return. There is a plan, Chair, to deal with that, and the CIO has presented as far as last night to deal with the issue about moving to electronic patient system. The same applies in terms of moving from telecom to voice over IP. And that for Chair will save us cost because Gauteng already has a LAN infrastructure. And when you move from telecom and you're using the learning Chair to expedite and harmonize the issues of communication. The rest of the issues that the colleague raises about the district presentation, I'll talk to it, the issues about training, the issue about the expediting the actual review of the clinical protocols in terms of what it can, in terms of allowing the clinicians to widen their scope. Chair, if some of those issues, I think we will need to pay particular attention within the confines of the resources that we are dealing with, Chair. But I think in a nutshell, Chair, we accept and we could have probably managed this process slightly different, but the presentation as consolidated is an outcome of a consultation, intervention strategy. Chair, maybe let me pause then. Thanks for the opportunity.
Thank you very much for those responses. Somewhere they need an extra theater. ABT in the meantime may help. HPRS system is also needed urgently. You have addressed it. The issue, national issue, will be the cross-border patients and the Itoloki for the languages. It's a national issue. Low-risk patients that are coming to tertiary hospitals and central hospitals remains a challenge. It must be addressed by colleagues here and their communities. Overcrowding, it's also something need to be addressed. Consumables shortage need to be addressed as a matter of urgency. Mobile clinic, it can work, it used to work in the olden days. BBAs, they really are causing some problems if they delayed personally on their own. ICU beds are also needed. If a woman dies because of pregnancy, the whole family is in trouble. Let's go out and continue doing our best, and let's improve. Let's phone others and ask, how did you do it? How are you doing it? Let's continue. I think we can do more. Let's continue doing more to protect the lives. Let us not be some of those who have contributed towards the death of someone because of our inactiveness. So you are there because you are identified to be there and make use of the opportunity. I want to take this opportunity to thank you for coming, and we have achieved according to our topic, and we will prepare our own report. There will be continuous follow-up on some of these issues, and we apologize for finishing after the time that is stipulated here. I think we have seen we were delayed first by the Hansard, then there were other challenges, but the meeting was very successful and fruitful. We thank you, and you must drive safely when you go home. We've got food, lunch for everyone. Don't go. And there will be some more because the CEO, they gone. So,
and MEC has added